ठीक है.
Stand in the tape. Yeah. So of course we can escalate as ma'am had told that I can take up questions accordingly, and please ask those questions if in case. So I hope my screen is visible over there.
Just don't begin now. She will give a little introductory speech from Clarinet. Yes, Clarinet people.
Yes, ma'am.
Now you can go ahead.
Yes. Very good evening and warm welcome to all the dignitaries present here. I am Momita from Clarinet, serving as the allocated session assistant to ensure accurate experience. Planet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that Planet serves as the digital partner for this event hosted by the Oncology Integrated Society, and the focus of today's session is precision oncology tools on breast cancer, hard to positive. So before into the session, I would like to inaugurate the program with blessings of Lord Ganesha. So I will take few minutes of yours to play Ganesh Vandana. Thank you. Now, can you please unshare your screen so that I can able to share my screen?
There is a lot of disturbance around.
Ma'am, I'm checking.
Later, we will
Please
mute
check.
ourselves and
वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा.
Hello and welcome all to this yet another episode of Cancer Webinar Series. It is a matter of honor and proud privilege to hold this webinar from the aegis of Oncology Integrated Research Foundation, Dr. Chaturvedi Cancer Hospital, Gorakhpur, and the Clarinet team. Today we have with us very learned, talented, astounding, and brilliant speaker, Dr. Piyush Bajpayee, a renowned medical oncologist who hails from Manipal, Dwarika, Delhi, and who shall be talking on precision medicine tools for early breast cancer, her HR positive cases. Not her, but HR, hormone receptor positive cases. Welcome, sir. We have with us a very respectable, renowned lady, Dr. Meenu Gupta, senior oncologist with a heart full of gold and elegance in her style, a woman full of knowledge and with radiotherapy oncology skills to chair the session of the webinar today. We also have Dr. A.K. Chaturvedi, who is the man behind the series and who is a renowned senior oncologist and owner of the very own Dr. Chaturvedi Cancer Hospital with a record experience of treating cancer patients for about 40 years and who has been past president UPARI and extra had trainings abroad and many awards and publications to add to the extra feathers in his cap. Once again, we welcome all the dignitaries, participants, friends, colleagues, seniors and juniors to this interesting cancer webinar episode. Hope this meeting, this webinar bridges our gaps, our lacunae, and enlightens us in our knowledge to the best possible way. Questions will be put in the chat box so that they can be discussed in the end of the meeting. Welcome all and good evening. Dr. Chaturvedi, please take the dais and introduce Dr. Meenu Gupta. Hello. Okay, little bit that I have seen. You have many awards and publications, and you are really very strong and resilient senior oncologist of your times. Until now, you don't look senior, you yet look very junior. And rest of the CV, we will present. Over to you, Dr. Meenu Gupta. Please introduce our speaker.
Thank you, Dr. Dipti, a renowned gynecologist, and yourself is a team leader at national level and international also, because lot of hard work you are doing persistently, Dr. Chaturvedi, with us. And I am going to introduce our speaker, Dr. Piyush Banerjee, a renowned medical oncologist, head of department from the Dwarika Manipal group of hospitals. And he had a lot of academic awards, publication, research in his basket, and he's not required a elaborate introduction. Most of the younger colleagues, students, they are listening in many conferences with the award of the European societies. So it is a very important topic. This is October is the breast cancer awareness month, and in our country, especially India, our Asian population, what tools we are going to practice with these ladies who are hormone positive. And we are next one now, we are going to listen from the Dr. Piyush Bajpayee. And Dr. Piyush Bajpayee, please, you can start your presentation.
Thank you, Chairperson, and thanks to Dr. Chaturvedi and ma'am for giving me this opportunity to speak over here. So I have sort of taken the liberty to actually keep the topic a bit. I would be touching on the basics of it only. So of course we can always discuss. I thought we will just touch the essential, what are the basic concepts behind it, and of course we can discuss thereafter. So the slides will carry very basic information as I'm putting this disclaimer. So genomic and advances what have happened and insight in the treatment of breast cancer. So the flow of the talk would be like this, that breast cancer and magnitude of the problem, approach to a patient of breast cancer, insights in treatment modalities, including genomics of breast cancer, and issues in young age breast cancer patients. So the magnitude of the problem, if we understand that breast cancer is definitely...
Appears to be an issue with the clarinet people. The voice is interrupted.
Am I audible?
You are audible, but in between the voice is getting interrupted.
Okay. I'll just check my internet connection.
It's a network problem because my phone is out.
Okay.
I will switch off my camera. That's what I will do.
Okay.
I'll switch off my camera. I hope I'm audible and...
Yeah, you're audible.
Okay.
You are audible.
Are my slides visible? The magnitude of the problem is the heading of the slide. Is that slide visible?
Yes.
Okay. So with this, thank you, ma'am. I'll just proceed as on the epidemiology part. So by the numbers, if we look, breast cancer is the most common cancer among women in India, and it accounts for 27% of all cancer in the women. So if you look at the mortality, basically, in India, it is 1.6 to 1.7 times higher than the maternal mortality rates. I mean, there are gynecologists listening to this talk. So you can imagine that amongst the female, breast cancer mortality is very high. As in, the gynecologist could probably correlate with the maternal mortality rates, and breast cancer mortality rates is almost almost 1.6 to 1.7 times. So it's a real problem that Indian subcontinent is facing as regards to a challenge to female health. Over 1 in 28 ladies are likely to develop breast cancer during their lifetime. And collectively, the US, India, and China, they account for almost 1/3 of cases globally. What is the difference between the West and India? What we are seeing is that we lose nearly 50% of our ladies once they are diagnosed with breast cancer. Kerala, Tamil Nadu, and Delhi have the highest rates of breast cancer in India. The reason that we are losing 50% of our ladies to this disease pattern is because we are detecting them late. To put some more figures, 2,000 new women are being diagnosed with breast cancer every day, and 1,200 are detected at later stages. In 2017, India had the highest mortality rates globally for breast cancer. So you can see that this problem is on the rise. And as you can see that the problem in the late stage of the breast cancer, so also the cost for late detected cancers, the cost increases because you use more modalities of treatment. And you can see that by 2030, the cases would double. So nearly 2 lakh is the projection per year. Right now, the last statistics was nearly 1.7 lakhs approximately, and it is nearly 2 lakhs per year. The 2 lakh ladies being diagnosed per year would be the number by 2030. So that's really worrisome. So just to touch base on if non-oncologists are listening to us, how do we diagnose breast cancer? So for example, a 45-year-old premenopausal lady is visiting her family physician with a 5-centimeter painless lump. The next approach towards a diagnosis of a painless lump is, of course, a proper clinical history, where family history is also important, a clinical examination. The basics are very important, as the clinical examination is of paramount importance for the surgeon to decide on the breast conservation versus mastectomy, and that this decision is taken up front. So as we know, and this is just touch base on the stages of breast cancer, that we know once the node is positive, then it's a locoregional spread. And of course, in stage 4, it's a hematogenous spread to the other organs. Once such a lady comes to the OPD, we usually do the clinical examination and then ask for a mammogram to be done. Of course, we appreciate that, what is the importance of BI-RADS. So if it's a BI-RADS 1, it is a normal mammogram, and the probability of malignancy is hardly anything. And of course, if it's BI-RADS 2, it's a benign lesion, could be a fibroadenoma, and probability of malignancy is again 0. If it's a BI-RADS 3, it's probably benign. So BI-RADS 3, one actually decides that less than 2% chance of malignancy, and one can keep under a short interval follow-up. And therefore, especially in a relatively dense breast where mammogram is done and supported with ultrasound, still there is a dilemma. And most of the times what radiologists do, what I've seen is at my center, they initially keep any suspicious lesion where they feel that it could be a fibroadenoma, but they feel that you need a closer follow-up. So they label it as BI-RADS 3, and they call the patient after 3 to 6 months, and a repeat ultrasound or a mammogram is done. Most of the times for a lesion which is slightly suspicious, it's better to label it as BI-RADS 3. But if in case it's looking like crab-like, a lesion is looking spiculated, it is looking, microcalcification is there. So these are certain signs where a suspicious abnormality is noted, and the chance that it could be malignancy is somewhere between greater than 2 to less than 95%. And of course, there is 4A, 4B, and 4C. So of course, anything BI-RADS 4 is supposed to be escalated towards an interventional radiologist for a core biopsy. And that is the important message I would want to convey. That BIRATS-4 is something where a core biopsy becomes very important. And therefore, BIRATS staging carries this importance. BIRATS-5, of course, is that the biopsy has already been done and we know, and we are doing a mammogram at a later date. And of course, biopsy-proven carcinoma, where it's done usually in the operation theater, where the appropriate action has been taken, and it's a mammogram just to see that everything is removed in toto. It's BIRATS-6. Ultrasound as a complementary test is required in young. So ultrasound is very handy, but is subject to subjectivity. And therefore, ultrasound has to be, complemented with mammogram, and mammogram in young ladies has to be complemented with the ultrasound because of the dense breast. But having said that, if you do ultrasound, you cannot leave a mammogram because you need to see the microcalcifications still, because that becomes important as well, and it's going to escalate the BIRAT scoring. MRI is having further resolution, is a very sensitive technique in early breast cancer, and especially in patients where you need to actually look at very small lesions, especially in triple negative breast cancer, where there is a history, strong family history, or a patient is BRCA1 and 2 positive. MRI is a very important tool in detecting such small speculated lesions, which is very important if we pick these lesions early and treat them, because early breast cancer, triple negative, as we understand, is it could become a sinister lesion. So especially the ladies who are BRCA1 and 2 positive, having a genetic history, these are the ladies where we usually go for MRI of the bilateral breast. Also, MRI is done in a patient who has had a history of radiation, and there is a high chance that after 10 years, 15 years down the line, this lady could be having breast cancer. So the probability is almost 15 to 20 times higher than the normal population. So there MRI is indicated. MRI is also indicated if in case there is a breast conservation surgery which has taken place. So for a breast conservation surgery, to see the breast with a better resolution, MRI is a very important tool. MRI is also important if in case there is a silicone implant in place, and MRI gives important information there as well. MRI has been an important tool in neoadjuvant chemotherapy patients. So there, in clinical trials especially, MRI has been an important tool to look at how the lesion has resolved. But the most important place where I find MRI in usage is that if there has been a genetic history, a family history, or a BRCA positiveness, their annual MRI is of importance. Talking about the core biopsy, now the FNAC has rarely taken a backseat. I would say that the FNAC might still have a place, especially if in case it's a very small early breast cancer, and in an elderly lady where we are mostly thinking that it is going to be strongly ER/PR positive. But most of the places, most of the centers, and most of the guidelines now are very, very clear that you need to have at least a core biopsy, and that is the importance. You need to have a good core, because you need to actually study the core in detail by doing the immunohistochemistry studies, by doing the molecular studies, and also identifying that if it is really a cancer and not just a DCIS, because basement membrane invasion is only appreciated once you have a core biopsy. So a true cut should be done in any breast lump suspected of cancer. And that's what I said, that why should you not just depend on a FNAC? Because with a core biopsy, you might just, with the FNAC, you might just overdiagnose, cancer. And we cannot really decide whether it's a DCIS versus breast cancer, because we do not see the basement membrane. We do not see the invasion of the basement membrane. We just see the cytology. With FNAC, we cannot do immunohistochemistry. It's very, very, very few centers do immunohistochemistry on FNAC, and that too is also not very reliable. Also, if a core biopsy is done properly, one can actually fix the core immediately in a fixative. So the tissue quality for a long-term research purpose or long-term molecular analysis is very well actually, because the fixity of the sample, the fixation of the sample in the formalin actually is immediate, and the quality of DNA because of that is of a better quality. If you want to extract DNA from the sample, the core biopsy is one of the better samples. Once all this is done, we talk about staging, and especially if it's a node positive or a triple negative or a HER2 positive breast cancer, we talk that we must have systemic imaging in place, especially a PET-CT scan, and that has been a real boon and advancements in staging of breast cancer, not just breast cancer but other cancers as well. I would not go into the details of this, but when we talk about the once the diagnosis is there on the table and the staging is done, and once you have the physical fitness, then of course we talk about what are the goals of breast cancer treatment, and if it's a local treatment or a regional treatment, the local and regional goals are to actually eliminate the disease, to cure the patient, to look forward towards surgery and radiation therapy at any point of time. Systemic treatment is to, of course, eliminate disease in distant organs. If we are talking about adjuvant systemic treatment, it is micrometastatic disease that chemotherapy or endocrine therapy or targeted therapy would do. If it is about stage 4 cancer, it is about looking at progression-free survival as an important endpoint. Of course, overall survival is the gold standard endpoint that has to be looked upon. Preserving the breast is of utmost importance, and preservation of femininity and confidence, both are actually these aspects underlie behind the fact that you need to preserve the breast for a lady. First, of course, we unfortunately see locally advanced cases at times where PUD orange is there, and we might not be able to preserve breast over there, but the attempts to preserve the breast should be done by the cancer oncology team in the whole. Sentinel lymph node biopsy, we talk about the breast tumor, we talk about the node. So node is another thing where we actually have seen that there has been a problem of lymphedema, which is very concerning for the ladies once they survive through this tumultuous journey. So sentinel node biopsy, we have seen that such ladies come to our office, and this particular picture is very disturbing for us also, and these ladies have to spend their whole life with this sort of situation, which is better options have come, and we all have realized, and we have moved towards sentinel node by actually seeing that which is the first landing node for the tumor from the breast lump, and that's the sentinel node, and you need to identify it with the dye, the blue dye, or by the fluorescent dye, so that the radiolabel dye, and you need to use a probe if in case you are using the radiolabel dye. So a combination of the blue dye as well as the probe would actually pick up better, would have a better pickup rate for sentinel node. And I would I already know that we have a great eminent radiation oncologist amongst us, but just to say that radiotherapy has seen advances in terms of the technology, the protocols, and the trials, which have all shown that the organ sparing is the normal organ sparing is becoming better. The preciseness has increased. So there have been definitive advances in terms of usage of radiotherapy, in terms of the techniques, the IMRT, the IGRT, where the heart and the lung is very well now protected. So I would not go into the details of this, but coming to the systemic treatment advances. The systemic treatment advances, we know that the chemotherapy has been there as the backbone of breast cancer treatment. The endocrine therapy, the hormonally active therapy, which the backbone of the treatment, which was tamoxifen and aromatase inhibitors, have been there. With the aromatase inhibitors having slight edge over tamoxifen in terms of relapse-free survival and PFS, both were better with the aromatase inhibitors, and is the preferred agent in postmenopausal ladies in PR positive. For HER2 positive breast cancer, a real boon was trastuzumab, when Dr. Dennis Lehman actually gave us this molecule. And thereafter, trastuzumab has seen further strides in terms of antibody drug conjugates, in terms of TDM1 and now TDXD, and of course, oral TKIs like lapatinib. So concept of adjuvant chemotherapy, just to tell the people who, doctors who are non-oncologists, basically adjuvant chemotherapy is quite similar to a combing operation. So it is basically to address the micrometastasis. So it is not for the macro disease, it is for the micrometastasis, and that's what adjuvant chemotherapy does. And usually the absolute benefit of the adjuvant chemotherapy for breast cancer lies somewhere between 6 to 8%. In addition to that, you have additional advantage for the trastuzumab if in case it's a HER2 breast cancer, and the total absolute benefit in that case goes up to nearly 12 to 13%. What is the concept of neoadjuvant chemotherapy? That is chemotherapy before surgery. So we have to realize that, we have seen an era where surgeons have operated largish lumps, surgeons have operated triple negative breast cancers, but now the realization that these diseases are basically systemic diseases, and therefore we must not miss out in order to, treat the patient better, do a surgery first. So here lies the concept that better treat the systemic disease first, treat it entirely with medicine, and then do the surgery, then do the local therapy. And therefore, we have to check that, we have to take these decisions in a combined, disciplinary meeting, multidisciplinary meeting, and such decisions of neoadjuvant chemotherapy can be taken over there. So the traditional approach so far had been that it's a node negative cancer, it's a node positive cancer, it's a node positive, then it was more aggressive. So now new approach, of course, is going towards whether it's a ER positive or a HER2 negative cancer. So if it's a HER2 positive cancer, it's called HER2 enriched. If it is ER/PR HER2 negative, that it's triple negative, it's also called basal-like cancer. If it's a ER strongly positive and a Ki-67 less than 15 to 10%, some places say 15%, Ki-67, some say that, less than 20%. So there has been this German study which has looked upon that, if the Ki-67, if it's a strong ER/PR positive and the Ki-67 is less than 10%, then such patients actually would have oncotype DX scores, which would be low risk. So that is important, that they have taken the Ki-67 value to less than 10%. So there is a very good corroboration. If you are seeing a lady with a Ki-67 of less than 10% and you are seeing a strong ER/PR positive, you might not really require to send a oncotype DX for testing. You can actually give hormonal therapy without giving chemotherapy, without sending oncotype DX for such patients. Then luminal BR patients who have slightly lesser strength of ER positivity and who have higher Ki-67. So the complexity of cancer cell it's there at the level of pathways and mutations, and it was a huge matrix before we actually analyzed that, after DNA sequencing, gene analysis, intrinsic subtyping, that we could realize that, okay, this is a breast cancer cell which is looking normal-like, or it is a HER2 negative, or it is a basal-like. So you can see that those red dots are basically triple negative basal-like breast cancers. The blue ones are the luminal A, and the white ones are luminal B. So this is how it is actually there. And you can see the estrogen ER positive breast cancer. What is the pathway which actually is active? And you can see estrogen receptor, which is overexpressed, and estrogen acting on that pathway. And the downstream signals are so important. So because the failure of the therapies which act on the receptor, cytoplasmic receptor of estrogen, And eventually, the downstream pathway, which is the PI3 kinase, the AKT, so it goes down to the nucleus. All these pathways can actually get activated once a tamoxifen or a letrozole is being given. So you can have a PI3 kinase mutation over there, and therefore giving a PI3 kinase inhibitor along with the fulvestrant becomes so important. Now, looking at the other pathway, which is the HER2/neu pathway, as you see, again, it's PI3 kinase or the RAS-RAF pathway, which gets activated. So either you can give a everolimus, along with trastuzumab to get that blockade, work in favor for you, or otherwise, sometimes you have to consider giving everolimus and HER2/neu, or bypass this by using a ADC, that is TDM1 or TDXT. So there has been definitely an evolution towards a personalized medicine. So earlier, the elderly were treated, by chemotherapy. The young were treated by chemotherapy. Now we used to differentiate by chronology and age, but now we are sort of identifying which subset, intrinsic subtyping, or the what is the biology of the disease. So whether it's a luminal A or luminal B. So because if it's a luminal A, you can actually give endocrine therapy. If it's a luminal B and or high risk or N2 positive node, N3 positive node, sometimes in N1 luminal B, you have to consider chemotherapy followed by endocrine therapy. This is an important tool which has come to our rescue. The data has been there, clear for risk score of less than 10. If it's a risk score of less than 10, there had been no ambiguity. You have to put on hormonal therapy. Now this data matured after the Taylor-X trial that if the risk score is anything in a postmenopausal lady less than 25, you can actually manage pretty well with the hormonal therapy. For a premenopausal lady, the cutoffs are slightly lower. So anything above 16 in a premenopausal, you have to consider chemotherapy. And definitely below 16, you can manage with endocrine therapy. But now some data is coming up this ASCO that if you look at the levels of inhibin between the age of 50 to 55, if you look at the levels of inhibin, and if the inhibin is showing that the lady has poor oocyte reserve, that is the inhibin is basically on the lower side, then you can actually consider adding hormonal therapy over there in such a lady who is on the borderline. Risk score of greater than 25 again was a clear identifier for chemotherapy and hormonal therapy. In HER2/neu positive and triple negative, we had the pathways very clear that if in case it's anything which is greater than or equal to T1B. Now T1B is also coming into that domain. Earlier we were talking about T1C. Now T1B also would benefit with HER2/neu positive, trastuzumab and pertuzumab blockade along with endocrine therapy. Triple negative, anything which is T1C and above is actually now getting neoadjuvant chemotherapy. And now pembrolizumab also, after an important keynote trial came, 522. So we must understand that these are fast-growing disease, and therefore, even in T1C, T1B, you have to consider neoadjuvant treatment over there. Systemic therapy, that is chemotherapy, what has been the advance that it might not be required for all. Oncotype DX is one example, glaring example. You have better delivery now. You have chemoports. So one can actually deliver chemotherapy without extravasation. Nanotechnologies has come. So basically without much of a drug reaction, you can deliver the drug. Better schedules in terms of dose dense schedules and better supportive care in terms of growth factor have come. So you have the chemoport, you have the targeted therapy in terms of nanoparticle therapy, and then you have the better support systems in terms of growth factors. So the patient has lesser neutropenia. For systemic therapy, that is the hormonal therapy, basically for estrogen positive subset, it is pretty well tolerated. It has some unique side effects, including articular joint pains, weight gain, hot flushes, and hyperlipidemias, making the patient slightly prone for bone loss, osteoporosis. So these side effects are unique. And we have to manage and navigate our ladies through these side effects. This is very important because they need to complete the entire treatment, preferably. They should take the hormonal therapy at least for 5 years, but now the data says that you have to go more if in case it's a nodal positive disease up to at least 7 years. At least 7 years. Well, there is data to go up to 10 years as well. So what I'm trying to say is in node positive, we must make sure that at least 5 years are for definitely completed, but we would, as oncologists, want to give additional 2 to 3 years to complete at least 7 years of therapy if the lady is able to take it well. So HER2 therapy, 1 year of trastuzumab is now a clear-cut winner. We were earlier debating whether shorter trastuzumab therapies, but now it is clear that better to give 1 year of trastuzumab, although trials like FINHER are there, which have shown short regimens, but now the data is pretty much there for 1 year. Managing metastatic breast cancer is a tightrope walk. We need to take care of our patients in terms of providing them good quality of life and taking into account a good progression-free survival as well as overall survival. So it has to be balancing act. And therefore comes the role of personalized medicine. We need to identify our patients, which would be benefiting with the therapy without much of a toxicity. And that has to be taken into account. And this is only possible by NGS analysis. So coming to somatic versus genetic mutations, as we understand that somatic mutations are the mutations which happen throughout the lifetime of the individual. And these somatic mutations basically are the mutations which eventually result into cancer. On the other hand, genetic mutations are transmitted to us from our parents. These are hereditary. We get one chromosome that particular chromosome, if it's an autosomal dominant, which is most of the BRCA genes are, then we actually see that disease manifests. Now, sometimes there is a 2 hit and the second hit comes in the form of somatic mutation over a period of time. So that sense 2 hit hypothesis, which eventually made us realize that, once this is there, then we actually have the actual carcinogenesis taking place. So sometimes it becomes really difficult to analyze that, what all mutations are happening new, because every time you cannot conduct a core biopsy. You have to look after, let's say a lady is progressing after 5 years in bones, and bones are a difficult site to biopsy. Also, to get a more complete picture of mutations happening, a blood sample, a liquid biopsy, a circulating free DNA sample works better. So therefore, these are the advantages of a liquid biopsy. And we all know that this is there in practice. And we can identify some mutations and act upon them. And one important mutation is PIK3CA mutation, which has been used quite often. And we can actually identify it through the liquid biopsy. Talking about germline cancers, basically, where and what about the BRCA1 and 2? So where are the BRCA genes? Well, it's on the chromosome 17 that BRCA1 is located. It's next to the TP53. And the BRCA2 is on chromosome 13. So this is located. And now what do these BRCA1 and 2 do? Basically, they repair. As you can see, they repair the DNA. Once the DNA is getting damaged, they are the repair mechanism. And if the repair mechanism is sort of missing, then, so everybody has the BRCA gene. So if the BRCA gene is not working, it is impaired, the mechanism of working is impaired, then what we call is as BRCA gene mutation. And this mutation has happened because of which BRCA gene is not able to work. So there lies the whole concept of genomic instability, because BRCA maintains genomic stability. But if the absence of the work in the absence of BRCA gene, there is genomic instability happening. So let's say over there that BRCA is working well, then the DNA is getting repaired properly. If BRCA is actually not there, it's mutated, there is another enzyme in our body called PARP. Okay, so this PARP is able to carry out some DNA repair work. Now, if you inhibit PARP also, then you are inhibiting, you do not have BRCA and you have inhibited PARP, then you are left with actually no DNA repair, and therefore no DNA repair results in too many mutations and eventually result in cell death. So basically, it is all about the understanding that the oncologists need to connect to the primary physician, understand the history completely. The various oncologists need to work as a team. When I say various oncologists, as in whether it be surgical, medical, radiation, also the pathologist, also the radiologist, they all have to work as a team to take care of the cancer patient. They have to work along with the family to build up the support system. So that's important. Some very important issues in young patient is that it's an aggressive biology in young patients, and there are genetic considerations of BRCA. These patients definitely need some loco-regional therapy consideration, breast conservation. Also, boost is there in radiation therapy. Adjuvant systemic therapy considerations have to be taken into account because they become long-term survivors, and therefore you need to take care of the heart, the lung, and you have to plan the treatment really well. Reproductive issues are there, so one must actually consider, before starting the treatment in a lady who is 30 years, 33 years, whether the family is complete, and if the family is complete, are they desirous of any more pregnancies? That should be, clearly laid out. And if they are, then they should be offered in vitro fertility treatment. If they are married, then probably embryonal cryopreservation is one of the best ways with best results. Otherwise, oocyte or tissue cryopreservation needs to be considered as the next best step. GnRH analogs basically help, but help very minimally, I would say, in terms of preventing fertility. Sexuality is also very important because there are several issues during the endocrine treatment also. So that needs to be taken care. And menopause and treatment-related issues need to be discussed with them in detail. Also, we should be ready to offer them some, pharmacological support once if they are facing this challenge. Hot flushes can be very well dealt with some SSRI, that is antidepressants, which work pretty well. And so on and so forth. These need to be discussed and managed. Lifestyle optimization is important for rehabilitation and getting back into their work style. So I would say that women are real tough soldiers, and we can see that men. I am actually saying this statement, but I'm pretty sure we all have seen with our patients small disease, and some of the men, most of the men would actually be in the bed, but women keep on still managing it. They keep on their daily course despite getting treatment. So with that, I would just end the talk, and I can take questions if there are any. I'm sure there would be questions, and as I just covered very basic concepts over there.
Dr. Chaturvedi, are you there? Dr. Meenu? There is some connection problem or what?
Okay.
Yeah.
Yes.
There was a
Meenu will
connection
ask.
problem. It was a very nice speech, very
अभी
crispy.
डॉक्टर मीनू को
explained.
बोलते हैं
Just a minute. Let me have the privilege of introducing Dr. Meenu, although because of the power failure, we could not do anything. So she is Professor Dr. Meenu is MD in radiation oncology. She is head at department and director tumor board, Begal IT and Cancer Hospital, Mohali, associated with Gyan Sagar Medical College, Chandigarh, HOD in Himalayan Institute of Medical Sciences, Dehradun. She was ex-fellow MD Anderson Cancer Center, Houston, Texas. She is member of so many organizations, ISO, ISNO, INBT, RSNA, Radiological Society of North America, at SRH University, academic in charge of Cancer Institute. She is also in charge of BSc Radiotherapy and PG PhD program. She was ex-assistant warden also. She was in anti-ragging committee. So she has got so many extracurricular activities.
Thank you.
And she is the ex-secretary, condemnation committee, CRI, secretary training, NABH chapter CRI, guide for many postgraduates in the radiation oncology. And she is keep on doing some radio talks on Radio Kushi for the cancer awareness. She has got many national and international publications, more than 110 papers presented in many conferences. And she has also organized many conferences like OncoCME 2011, North Zone ROI 2013, NeuroOnco CME in 2014, Gynecology 2014, Neuro, and so many conferences. She has won many prizes and posters and presentations. First in Indian ICR, which was held in Delhi, she also presented in that. And she has got Rashtriya Gaurav Award, Abdul Kalam Award, Mother Teresa Sadbhavana Award, Best Chikitsak Award, Best Citizen of India, and Doctors of the Year Award, Uttarakhand Rashtriya Chikitsa Seva Bhushan Samman. So many awards she is holding. So here's my chairperson is. Now you can comment on.
Dr. Chaturvedi, thanks a lot, and we all there because of the efforts of your academic interest for the interest of national and international students. So we are coming back to our topic, and this is actually very important of the carcinoma breast. And today the talk was limited about the early breast malignancy, and we had Dr. Piyush. We listened him very important and very nice presentation. So easily you have explained about the molecular oncology in case of CA breast. So if any question, then I will extend my own interaction with academic interaction. If any question from any side.
Yes.
So Dr. Okay.
No, I am not asking. The clarinet team, is there any question from the delegate link? Kindly paste it.
Okay. So Dr. Piyush, that was very informative talk, and
Thank you, ma'am.
actually what we are experiencing in this era, this era is actually very fast. There is a we can say we are in between transition, or we are held up between the molecular oncology. There is a set of we can say the practitioner as well as the public who can actually understand the significance of molecular oncology, as you told about the NGS and all that. But we have a group of the public population as well as our clinician, still where including the public also, where there is the totally lack. Still we had to work a lot about the awareness. So as far as the early tools about their lifestyle changes, their dietary habits, change of their lifestyle is still important. And I would like to say, if you are agree with me, because our country still the resources are, I would say, not this era limited resources. I wanted to change the term, but in between we are catering a lot of population where we can adopt these early tools, especially breast screening examination, self-examination, their lifestyle changes. And sometimes the public actually couldn't understand the lack of skill, manpower. So what is your opinion about the screening mammography? If it is you, I wanted to listen from you, like the screening mammography or the breast self-examination, because sometimes we are teaching in our public programs also, but still we are lacking the skilled person who can actually teach and the understanding of the very because I happen to work in the interiors for our camp campaigns and awareness campaigns, where is a set of population they can actually miss. So if there is a mammography, a successful screening mammography in our setup, what is your opinion for this group of population?
Thank you for the question, ma'am. So basically, you are very right, and you said that we do face mammography as in terms of the machine, the equipment, the quality of mammogram, as well as the technicians who do it at times, and also the paramount of importance is the interpretation of what we get in hand. So all this becomes a challenge. At times it's easier for us sitting in cities at times to just spell it out, but as you said, that going towards camps and rural areas, basically that challenge, and we're talking about masses, and we know that India still lives a lot of population in the rural area. So the major thing what we must spread as oncologists, as doctors, is that self-breast examination, of course, is important, but the only thing is self-breast examination requires a disciplined patient, and such a disciplined patient is actually a very proactive patient. I'm talking about a patient who is not disciplined. How to go about that patient, because that patient usually will be the one who would neglect, because somebody who's doing self-breast examination would knows how about the protocols, is definitely a more proactive patient, is a more proactive and extrovert individual, and will definitely come out with the problems to the doctor or to the medical community very early. So of course, nonetheless, self-breast examination must be taught to young ladies, especially once they are into college after the age of 18 years. Every girl must know self-breast examination. So that, having said that, the emphasis should be on clinical breast examination. So whenever there is a visit towards a family physician, gynecologist, or you know the physicians, they should be trained towards doing a clinical breast examination, which could be a very important thing. So the lady is visiting the gynecologist for some reason, uh, let's say for per vaginal discharge. The clinical breast examination, if that visit is almost after a year or two, then a clinical breast examination should be encouraged by the gynecologist at that point of time. So that's what is the message that I would want to say, that cancer screening is very much doable by family physicians, and this sort of cancer screening can pick up, this is more of an objective cancer screening, because self-breast examination is more of a subjective thing, but CBE becomes more objective and is much more doable, and is and can actually catch a lot of lumps which can be treated well.
Thank you, Dr. Piyush. Absolutely, I'm agree with you, because the disciplined patient are the group of patient, what population we are catering. Because in our country, we are the totally have the imbalance. One set of population, very high socioeconomic class, well educated, they are well disciplined. But if you go to into the interiors, where we are getting even, I happened to meet during my awareness camps program, young female 18 year, 20 year, and I have to document and mention the areas like interior of the Bijnor, the area inside the Chandpur, where one of the camp screening program, I got 8 girls out of the 65 patients who have examined of the mixed population, like so 8 girls I 8 girls I found with the multiple lumps. Some were although fibroadenomas. 2 or 3 were not motivated for the further follow-up. So this is actually a problem in the interior of the villages, and I would wanted to recommend like ASHA workers, where they made many of the OPS and gynae programs successful, polio eradication programs. So we should encourage like ASHA
Absolutely,
workers or
absolutely.
trained, I mean our medical practitioner to approach the setup for the early diagnosis. Because once these girls, this population, they're coming late stages, and quality of life is also suffered, and yeah, definitely economic burden is also once from the no pet to we are going towards the pet imaging, and these things actually some protocols have to adopt it for our own guidelines for our own country for such type of population.
Totally agree, ma'am. I think
So,
so. You rightly pointed out ASHA workers are one particular important human resource in healthcare in India, where we can actually, take their help. In fact, there was this recent last year article in Times of India where they had published the report that how blind ladies are able to
Yes,
actually detect, because
yes,
they are examining the patients, the population very calmly, and they are using their tactile sensations and to
yes,
match the
lasers and all that. Yes,
very
exactly.
sinister breast lump. So these ASHA workers can also be trained very well, in tactile sensation, the way clinical breast examination is done. And we have seen successes in terms of detecting cervical cancer in a rural population in Maharashtra, elsewhere in India.
Yes.
Likewise, I think so, clinical breast examination as well. Totally agree with you.
Totally, because this is very important. Breast cancer incidence has been increased. It has overtaken the cervical malignancies, and we have to stop somewhere, like at least the breast cancer awareness program. Meanwhile, simultaneously, we have to utilize to prevent the over treatment, over diagnosis, as you mentioned in your slides, with the molecular oncology test, like because we have evidence-based data, which risk group like Oncodex and all that to be given chemotherapy, or which group has to be avoided. Thank
Yes.
you.
so another thing I want to add, whenever we go for the in the periphery for the awareness programs, we should ask them that every node inside the breast is not cancer.
Yeah, this is
80% of the nodes are negative. So don't be fearful. You come to the doctor, you go to the doctor and get yourself examined and remain free. So this is one very important thing, because some people, they are not going to the doctor because they will diagnose as cancer. So tell them that 80% of the nodes inside the breast are negative. They can be easily measured. So this is additional thing.
Very excellent.
Any other question? Dr. Dipti?
No, no questions. I was just appreciating the way all have discussed from preventive aspect to the excel aspect of neoadjuvant chemotherapy and HER2 new and HR positive receptors and luminal subtypes and PKL, whatever it was. It was interesting to listen all that, and the new advances in breast cancer as good to improve the longevity. You will give your opinion what you are doing, because I am just a gynaec. So you will tell you are treating every time. But I've seen your cases also. Before opening this hospital, when you were in other hospital, that patient had come here, and she lived for around 34 years with breast cancer. I think
Longer survivals are available in the breast cancer.
chemotherapy only.
So that's not a big issue, but yes, they should be aware about the early diagnosis and everything. So it was a
Yeah.
nice presentation. And thank you, Dr. Piyush and Dr. Meenu, for chairing the session.
Thank you.
Thank you so much.
Thank you for the invite. Yeah.
Thank you, Dr. Dipti, Dr.
Thank
Chaturvedi.
you
Thanks so much.
for accepting the invite. Thanks, Dr. Piyush,
Thank
for
you.
such last moment elaboration of your just basic presentation. It was really very quick of you. Thanks for accepting the
Nat is very bad.
net was bad this time. It was not supportive.
This is
But
for the
anyway,
first time.
first time it happened.
Yeah.
Maybe it was clashing with some other webinar of the
Okay.
other side.
So
And
thank you so much. Thank you, everyone.
Thank you.
thanks for your support. Thank you all. Okay, so we take your leave for next time. Thank you.
Good night.
Good night.